2, 3. I'm Gary Korolev with Sovereign Wealth Management, and today we'll be discussing Medicare with the most knowledgeable person I know in the space, and also the person with the coolest last name I've ever come across, is Kim Sixkiller. Please say
Hey,
hi.
hi, Gary. Thanks for having me. It's very kind of you.
Sure. And so Kim has several decades of experience in health insurance, in the health insurance space, and she deals with different types of Medicare coverage and advises clients on different plans quite a bit. So I felt like, given how many questions we get from clients in our seminars or from prospects in our seminars regarding different options when it comes to Medicare, we really would be doing a service for our clients as well as potential prospects or just people watching this video on YouTube, and to give them just an overview, a basic overview of the Medicare space and how different types of plans work together and what may be best for different people in different situations. So to start, what is the difference between Medicare Part A, Part B, Part C, Medicare Part D, and Medicare supplements?
Yeah, absolutely. Thanks again for having me, Gary. So when it comes to Medicare, it's a little bit of an alphabet soup, right? We hear people use kind of that analogy all the time. And so when you're joining Original Medicare, typically it's going to be when the person is turning 65. There are reasons that people can join beforehand, depending on their disability or certain end stage or terminal illnesses. But when people are eligible, they're normally going to join Original Medicare, which is Part A and Part B. So first, Part A is going to be your in-facility hospitalization treatments. So I tell people to think of this as what's being used as kind of like a room and board. So Part A is going to cover those inpatient stays. Traditionally, most people will have Part A at no additional cost because they've paid into their Medicare, Social Security, and FICA taxes for 10 years or 40 quarters. Now, if they haven't, they can often qualify by a spouse or even sometimes an ex-spouse. But if for some reason they haven't qualified, their cost structures, that kind of thing. But that Part A structure is going to help offset cost when you have to be in a hospital, in a rehab facility, some kind of skilled nursing home, and even the use of hospice. Part B is your everyday insurance. So your Part B is that medical insurance. It's what people use most often. So whether you step on a nail and end up using the emergency room at the hospital or at the emergency room but don't get checked in, going to see your regular prescription, your regular primary care doctor, maybe you need to have labs, blood work, all those kind of things fall under that traditional Part B. Part B does have a monthly cost associated with it, and it's going to be based off of the client's adjusted gross income. That modified adjusted gross income, when they join, is a 2-year look back. So anyone joining this year, we're going to look at the 2022 tax returns and the 1040s to see how are your taxes filed. Are you single filing? Are you joint filing? Or are you married filing separately? See what the 1040 says on that adjusted gross income line, and then figure out what each individual in the household joining Medicare will pay, because it's not a household cost, it's a per individual cost for who joins Medicare.
Okay, interesting. And what about Part C?
Yeah, so once you've joined Original Medicare, now we need to make sure that you have the coverage that will take care of you. One of the things that the federal government says is once you turn 65, you need to have creditable coverage. They define creditable coverage as having coverage that is as good or better than the Medicare minimums. So you have a couple ways to get that. The most traditional is you can either add Part C, which works really to step in and take the place of Original Medicare, or it's an assignment. So in a case like that, you're still going to pay your Part B every month, but independent private insurance companies offer plans that you can join. And so instead of the original Medicare system paying out when you're utilizing these bills, your private health insurance is. So within that Part C, many people will have their prescription drug plan. There's a couple instances where people may not because they have drug plans other places. But if that private care Medicare Advantage isn't for you, you can go with Part D. Part D is the prescription drug plan. It's that standalone drug care. Again, available inside of a lot of Medicare Advantage plans. And prescription drug plans are set by the government as far as this is what it needs to look like. You have to have that to have creditable coverage once you're 65 with your healthcare. And if you go with that standalone Part D because you don't want to reassign and move away from original Medicare, a lot of people will partner that with Medicare supplement plans.
Okay. So how do Medicare supplements work? What are they? So how are they different from Medicare Advantage, which is Medicare Part C?
Yep. So what I always tell people is once you've joined original Medicare, now we're looking at your path, and you have two paths. You have the pay me now path and the pay me later path of your health insurance, right? So on the pay me now side of the scope, you have Medicare supplements. These plans are heavily regulated by the government as far as they have minimum requirements that they are supposed to have. And they are allowed to cover certain things, not allowed to cover other things, such as you cannot have a drug plan within a supplement. And you prepay for these plans. So you pay a monthly fee. So when, not if life happens, because we don't get healthier as we age, you have to pay out significantly less at the time. So now people turning 65 after 2020, they can pick up plans such as a Medicare Supplement Plan G, pay a monthly premium, whatever that premium is in the area. For example, I'm in the Kansas area. It's pretty common when you're turning 65, you can get a plan for about $100 a month, right? And then the only extra expense I have for those medically necessary Medicare covered is I need to pay my Part B deductible. This year, that's $240. It changes every year. So supplements, it's basically like prepaying for when life happens, right? And then we partner those with a drug plan. We know we've got credible coverage. We can move on down the line, look at what ancillary or preventative services we want to cover separate. On the other side of the coin, sometimes you have clients who feel like they're super healthy and they don't want to spend the money that they don't need to monthly, or maybe you have someone in a situation where they simply just don't have it. And that's where they'll look at Medicare Advantage plans. That's that pay me later side of the coin, right? So when you're going with that pay me later side of the coin, again, you're reassigning your insurance coverage from the responsibility of original Medicare to this private insurance company. These insurance companies still have windows and guidelines they have to follow, but they have a lot more leeway in their plans as far as what they can cover, what they don't cover, how much things cost. And so on those plans, a lot of times you'll pay very low, sometimes nothing monthly for that plan. And then you pay as you use your insurance for traditional services, like you may go into the doctor and you have to see a specialist. Well, your explanation of benefits and your contract with that company says, I pay $50 to see a specialist, or I have to have a surgery done where I'm going to be hospitalized for 3 days. Those daily hospital rates may be $290 a day. And the max out of pockets that they can charge you, again, are set by the federal government, but you pay as you go. So if you're not using it, you're spending significantly less out. Those are the main differences. But then in the recent years, we've seen a lot of like perks added to Medicare Advantage plans. So a lot of those companies, to make their plans more appealing, but also to try to help take care of clients, have added different benefits. So there's tons of benefits depending on where you live and what county you're in. I won't really jump into any of them specifically today, but it's things that you can pick up on the open market as an ancillary or not. So like dental, vision, hearing plans, gym memberships. Again, a lot of stuff that's available on either side of the house. It's just how people package them.
Okay, great. And of course, to get any of those specifics, you can always just have a conversation with a knowledgeable professional in the space to get some of the specifics available, because there's just so much out there. This is not the time to discuss it, right?
Absolutely. So that's probably the biggest thing as people are, kind of aging into Medicare, joining Medicare. It's not that there's a lack of information. There's actually just an overflow, right? And just that overflow of information, and also bad information, wrong information, or partially incorrect info, right? Because you and I both know that my dad could call your dad and say, this is the plan you need to be on. This is a great plan. Well, my dad lives in Tennessee and yours doesn't. So that plan may not even be available depending on what they're on, right? So it's really, really key for clients to go ahead and work with somebody who this is what they do. So that's where you and your team are great, because you really focus on it and you make sure that you know your marketplace. And what's great about, I think, Sovereign, is you guys are independent in the way that you don't partner with one carrier. You say, no, we're looking at all these carriers and we want to do what's best for the client. So it doesn't cost them anything to review their Medicare situation. Why would I want to do something for free that someone can help me with and know that I look at everything?
Right, makes sense. So the next logical question would be, when can someone, or when should someone be signing up for Medicare, or change between Medicare versus Medicare Advantage versus looking at their Part D or Medigap, which is Medicare supplements?
It's so funny. I'm just going to caveat this because I know when I talk about it, it sounds like if and but, because there's no gray, black and white lines. Really, there's all these if, now, whens. I liken it to the books when I was young. I'm going to age myself, that were like the choose your own adventure books. You get to the bottom of the page and you're like, if you want to do this, go here. So with most clients, when they're going to be aging into Medicare at 65, they should start looking at what they're going to do about 3 to 6 months prior to their 65th birthday. And the reason I say that is it's going to take some time to figure it out. 3 months prior to your 65th birthday month, 4 months if your birthday's on the first of the month, but about a 3-month window, right, is when you can actually go. They can come into your office, sit down with you, you evaluate their personal life situation, because it's a very personal decision, and say, okay, this is what we want to do, right? Now, what I love about your firm and the fact that you all do full planning, right? You're not just a Medicare shop, is your clients are having conversations far sooner that involve things about Medicare, because hey, there's a 2-year look back. So if I wait until 3 months before 65, and I worked with Mr. Advisor down the street who didn't bring anything up, and they decided to do a Roth conversion on my money, right? Now, I pay a lot more for Medicare, because again, remember, we pay based on what our tax return was 2 years prior. And that's what I love about you guys, right? Like you and I have already talked about, you've helped people who come in your office and they're like, I'm paying, $350 a month for Medicare. And you're like, oh, we need to change that. Like we need to file, like this was done because he didn't pay attention or didn't disclose to you that we were going to need to do this exchange. So they definitely, minimum 3 months prior, need to decide, hey, do I want to pick up Medicare? Am I still working and I don't need to? Is my insurance creditable? But I mean, working with somebody like you, even in advance, because it's one piece of that whole financial wheel. I mean, they're going to have conversations about things like IRMA, income related amounts, and all that far sooner. So,
okay, so great points. So then if somebody already has Medicare and maybe they're not happy with how much coverage they're getting on their drug plan and so on, and so when can they look at other options like Part D and Medicare Advantage, Medicare supplements? When can they make those switches?
yeah, great question. So people who are already currently out there on Medicare, kind of, rolling through the days, unless they have some kind of special election reason to change, moving across state lines, county lines, things like that, where your plans are different. If we just have a standard, hey, I just don't know that I love my insurance, or I want to see a doctor that's not in network, there's a thing called the annual election period. This runs from October 15th to December 7th every year, right? And this is, I tell everybody, they kind of know when it is. If you pay attention to the TV, it seems like every fifth commercial is some kind of Medicare commercial, right? You see things that come out there for the big houses. During this window, you can choose to move in or out of a Medicare Advantage plan. You can go from one Medicare Advantage plan to another. You can potentially leave your supplement and go to an Advantage plan, or go from an Advantage plan to a supplement. Depending on the state, there may be underwriting, different kinds of things. But you can do all of those things during that window. And then whatever changes that you're making, including going from one drug plan to another, they take effect on January 1st. So it's like an open enrollment for a business. But that is that window that traditionally you want to look at things.
Okay. And as far as Medicare supplements, now is the scheduling different as far as flexibility of changing from one Medicare supplement plan or Medigap plan to another Medigap plan?
Sure, yeah. So if you're only looking at your supplement, you're not taking your drug plan into play, and you are already on a supplement, there is no window for that necessarily. You can do that any time of year. But depending on the state, like I said, you may have to go through underwriting. There are states such as Connecticut where they have kind of that guarantee issue. They can make a change at any time. Or California, for example, they have what's known as a birthday law, right? So there is a window around their birthday they can make certain changes. So typically the answer is no, anytime, standard underwriting. But again, depending on your state, you may have some things going on. So that's why people should work with somebody who does insurance in their state, or is at least licensed in their state, because then they're familiar. For example, I know you're familiar with many state laws. So
Okay, great. So how does Medicare Part D, so the prescription drug plan part of Medicare, work with Medigap or with Medicare Advantage? How is it packaged together or separately?
yeah, so with the exception of someone who has some kind of drug plan outside of the Medicare system, right? We're just going to take that off the table to face what most Americans look at. Prescription drug plans are required as far as having creditable coverage. If you don't, the government can give you what's known as late enrollment penalties. It's a clock that starts and frankly never stops until you enroll. So you can end up with lifetime penalties, lifetime late enrollment penalties. So again, with a supplement plan, you would pick up a standalone plan. All of these plans, supplement plans, drug plans, Medicare Advantage plans, they're all with private insurance companies, right? But they have specific rules and things they have to follow. Medicare Advantage plans, if you don't have a drug plan, they're built into the plan. You cannot typically have a traditional Medicare Advantage plan with a prescription drug plan. You can't have both, and the Center of Medicare and Medicaid kind of oversees that. So I have seen situations where clients were confused. They'll walk in my office and they're like, oh, well, I enrolled in this and I enrolled in this, and come January 1, I only had this plan because the last plan in wins, if you will. But typically you're putting it with it because it's within the plan, or with a supplement, you're going to partner something together with it. It's funny you ask about drug plans, because that really is the big thing happening this year, right? So we all, I, many Americans, but absolutely, hopefully all Americans who work in investments are familiar that, the Inflation Reduction Act that was passed, signed into law by President Biden. It is a tiered act that is rolling out over the next 10 years, right? We've seen a bunch of cost saving metrics around drugs, $35 insulins, qualifying insulins, that kind of thing. Well, this year is a massive change. It is arguably the biggest change in Medicare since they made changes in the early 2000s, right? And so what's happening is this year, they have completely redesigned the prescription drug plans. They have closed or eliminated the gap period. We've all heard of the donut hole, right? You hear those things about the donut hole. People come in your office and like, well, I heard something about donuts. And you're like, yeah, let me get into that. Well, the gap is gone. The donut hole is gone. So what they've done with drug plans now is, and it's the reason why everybody on Medicare needs to at least look at their stuff this year. I know I keep saying that, but you will go in and you'll evaluate your drug plan. And this year they have established the 2025 deductible is going to be $590. That's up about $45 from last year. So the plans are required to have a deductible period where you pay 100% of your costs up to that limit. $590 in 2025, right? So plans can decide to have lower deductibles. They can have no deductibles. Normally you see that offset in a premium or whatever, but with a standard plan, $590 deductible, you pay up to 100% to that $590. The plans still work like usual, where you'll have medications that are in formulary, which means they're approved medications, right? So carrier A has this list of formularies, carrier B has this list of formularies. Carriers can kind of do whatever they want as long as they follow the rules of, hey, in each tier, I have a medication that covers all of, so I have blood thinners and like all these little rules, but they don't have to cover every med, right? Some of those top 10 medications that the Inflation Reduction Act said, hey, let's negotiate on these first. Farxiga is an example of one. They're not on all plans. And even if they are in your plan, they're probably a tier 4 medication. That means they're specialty. They're super expensive, right? We've all heard of those things happening. Well, now the new plans say, okay, as long as you stay within the rules of your plan and follow the true out-of-pocket expenses, the maximum amount that you will have to spend for your medications in 2025 is $2,000. Now that is down from this year and significantly down from 2023, right? It's a huge savings. What many clients won't understand is, what does true out of pocket mean? And how do I make sure that my meds are handled right? And so this is one of those places where I could explain it for 15 minutes, but the simplest thing to say is they need to work with someone like you, right? They would work with you, they'd talk, schedule a meeting, fill out a form that kind of explains to them, explains to you, here's the medications I take, this is the pharmacy I like, so that you can go online. You have access. I know you've talked to me about the systems that you use. You have access to see all of the plans in the nation, even if you don't have the ability to sell them, right? Because maybe you're not contracted with certain carriers, but you can see them and you can say, okay, based on the meds you take and the pharmacy that you want, this is the one we need to put you in. This is how you make sure you're in that true out-of-pocket expense. So your meds stay the same and we can save you money. The one other big change, there's a couple things, but the other big change in that is there is going to be a thing called the discount program. It's the Medicare prescription drug discount program. People are already calling it the discount program because we love our shortened names, right? I'm sure it'll have some kind of acronym soon that we can throw out there. But it's going to allow Americans automatically to be able to go onto a monthly plan to pay for the meds that cost a lot more, right? So if I have to take Ozempic, for example, and maybe that costs me $350 to fill it, I'll be able to enroll in basically a payment plan that will allow me to pay monthly for that med. So it'll basically, with that situation, right, we know I'm going to hit my $2,000. So depending on how I set up my plan, I could split $2,000 up over 12 months and go, okay, here's what I'm paying. The government was very sharp when they did this because they did a couple things with it. The first thing is they made it so you can enter and exit at any time. So in January, if somebody doesn't have the money, but then they get taxes back, let's say in April, and then they have it, they can go ahead and pay it off soon. There's no penalty, right? They're also going to keep that payment completely separate from your drug plan. So you put them in a plan with the purple company and they pay $10 a month for their drug plan. That's their premium cost, right? They pay that $10, they're getting that taken care of, but something has happened. There's some kind of situation that they can't come up with that, let's call it $170. And they fail to make that payment. Let's say they didn't make it for 3 months. The drug plans legally cannot kick them out of their drug plan because they didn't make that premium payment on their payment plan. So they can still kick you off the plan for grace if you didn't pay your premium payment of your plan, right? But they're keeping these separate to make sure that Americans don't just lose their drug coverage. And then the plans, these payment plans on the meds are being traded just like medication, just like typical situations where, depending on your state and the federal laws, they can come after you with the collections and different things. So different HIPAA things. So that's a lot, but those are the main changes that make me say, if you're on Medicare, you have to work with someone this year and just make sure you understand what you need to do to make sure you're playing ball to be your own advocate, right?
Okay. So thank you for that thorough explanation. Those changes that are taking place starting next year, those are the most extensive changes that I remember happening in quite a long time. Is that right?
Yeah, since the early 2000s really is the last time that they had this kind of an overhaul with Medicare. And like we saw back then, I'm aging myself, but like we saw back then in the early 2000s, there's a process called crosswalking. Really what it is every year, those of you who are on Medicare know, and Gary, I know you've seen them and worked with clients on them, you get this thing called an annual notice of change letter, right? The letters we get from the carrier that says, hey, on this ANOC or annual notice of change, your plan is going to look like this next year. Well, when we have massive changes like this, we do have carriers who exit the market. We have carriers who drop their plans, right? It will most likely, I would hypothesize, look different in the landscape as far as one carrier probably won't have 8 plans available in a market, maybe 3, maybe 4, like, but so those ANOCs or annual notice of change letters, when they go out, Gary, you get it in the mail, or warning, you're on electronic stuff, so it doesn't ever come in the mail. It just loads to your website or it emails and you never check it. It tells you, hey, we're taking you from this plan to this plan. And you don't have to do anything. This is what will happen if you do nothing, right? Well, we all know that that's not always the best thing, and doing nothing is not always the best thing, right? So it may move you to a plan where one of your meds is no longer in formulary. Now you have a problem, right? Because if you take that Farxiga and it isn't in formulary, what you have to spend to fill it isn't going to count toward your max out of pocket. It's not on your formulary. So big difference.
Okay, great. So we've covered the basics and we've really gotten down into some of the details as well. And I feel like really at this point, I think one important area we should cover is really how somebody should approach Medicare. Now, in my view, based on what you've mentioned and how we work with clients as from a financial planning approach, so there's a strategy which we gather information about the person's resources, their goals, and there's a lot of detail involved. And then based on all of that information, we make decisions. So Medicare, from what it sounds like, someone's strategy for their health coverage in retirement, there should be the same approach where you want to make sure that your health care, Medicare professional that you're working with to help you get advice, or if you're doing it yourself as well, you take a systematic approach, meaning you write down all the medications you take in great detail, how much, how often it's refilled, how much it's costing you, what your current plan covers. And then you make sure that you have a knowledgeable partner working with you on this and figuring out what the other options are out there that may help you save money versus what you're paying right now. Because often what we've come across is somebody will have a plan which they got into years back, but they've been afraid to get out of it because they loved it so much in the beginning, but the costs have risen, the medications they're taking have changed, and they're still in the same plan because they're afraid to leave it, just because they're afraid to change and then lose some kind of coverage or make their coverage worse, something along those lines. What would you say to that?
Yeah, I think that it's why you see so many more people. I think one of the biggest things that we see really worldwide, but definitely nationwide, is that convenience, right? I don't want to have to explain to 5 people what my retirement goal is, right? So I don't want to have to explain that I want to do XYZ to this person and then this person. I want one house as much as possible that's going to be able to understand and help get me there. And so I think that that's the great thing about firms such as yours, Gary, is what you've done that's really unique is you say, okay, whether I start working with you at 30, whether I start working with you at 35, 55, you know, wherever you're at in that investment scope, the first thing that I understand is your risk tolerance. You know, there's a big theory on risk tolerance, and to, very quickly surmise it, it's just, hey, if you're super aggressive and I'm super conservative and we both invest the same amount of money for 20 years, we typically will land about the same place, right? Because you had some ups and flows when I didn't. And so not exact, but that's the idea behind it. Well, if you know that about me, then you know who I am and you know my risk tolerance and how tolerant I'm going to be to the risk of when life happens with my health, right? So that goes into play. And I think it really plays down to, in my advocacy for seniors and for really all Americans who are looking at their healthcare, is I call it an enrollment red flag. If someone is helping you and they don't know you, and I mean know you as far as taking the time. I mean, you're great at what you do, Gary. So obviously you can sit down with a client, they've given you information in advance, you have their drugs, right? So when they come in, they've signed that scope of appointment a couple of days before. So you're ready, but then you're still gonna ask them questions, right? Like, do you want to travel? What are your plans? If something happens tomorrow that you get cancer, how are you going to cover that for your wife? Like, how are you going to make sure she's not? If somebody hasn't taken the time to really know you, how do they know what's going to fit your situation best? And then you start to see those red flags in the fact that maybe the same office is selling the same carrier to everyone. Well, it can fit a lot of times, but I would say that it's very rare to find 10 individuals who have the same exact plan need, right? And so that independent house like yours, it's gonna make sure, hey, we understand, we're asking the questions, we know your risk tolerance. I know you want to travel internationally every year. Now, that doesn't mean that you can't have a Medicare Advantage plan anymore. There are plans that have international emergency coverage, right? But they don't all have it. So if you haven't asked me, how do I know you're going to cover it right? So yeah, it's just about really being with somebody who is a partner with you on that life plan, because you didn't work hard your entire life to have to sit on the couch and spend your money on your health bills and your drugs, right? Like, hopefully we get to enjoy our retirement.
It's a great point. Thank you for that view and explanation. And one area which we actually didn't cover, just because of the amount of time that we have to talk today, and the fact that it's its own little universe, you could say, is coverage for federal employees and for those who served in the military, and how those different plans like the VA and TRICARE for Life, how all that works with Medicare. And maybe if you could just say a few words about those those types of federal employees and military personnel who you come across in your profession, and how you feel about the strategy there, or maybe just a few points to start thinking about the strategy.
Absolutely. So they're both separate, obviously, federal versus the VA. So I'll kind of break them up, but they have kind of the same idea behind them. And frankly, many people have both, because many of our veterans, thank you all for your service, oftentimes end up in federal jobs. So that's great. But both of those are healthcare systems and plans that historically have just been phenomenal for the most part, right? One of the important things I'm going to start with federal employee benefits, is in the 19 years that I've been doing this, I have learned and been blessed to learn through clients and stuff, all federal plans are not created equal. They're not all the same. People think they are, but they're not, because the plan available to my dad through the Nuclear Regulatory Commission was not the same exact plans available to my uncle, who was a United States postal worker, right? And so first and foremost, make sure that the person you're working with understands what you have. I always say the best way to do that is the person should probably ask to know, what's your plan? Can I see your card? What are your coverages, right? And the reason I say that is because what we're learning today, just because of the cost and inflation and different things, is staying on your federal government once you're retired, once your spouse once they are also on Medicare, they're retired. It's not always the most cost-effective situation. Sometimes it takes really putting a pen to paper and writing down all those costs and seeing it. I had that conversation with my parents several times before my mom went, oh, maybe we don't want to do this anymore. And I was like, but there's definitely a difference. Federal workers do have great insurance, especially while they're still working. And that's a great point as well. I think maybe we touched on it, Gary. I know you've had clients that you've said, hey, I know you're 65. I know you're eligible for Medicare, but you're still working. You're planning on working until 68 because you're Social Security, this is your max age, like you're not stopping. So no, based on your plan right now, you don't need, nor should you take Medicare because it's not as, financially sound. So, hey, we're going to go ahead and Part A is free. I'm going to go ahead and do that enrollment. We're going to defer Part B. And then once it's time, we'll do the sign up then. And, you've done the forms to help them prove their creditable coverage and roll in. But just because you are at the age doesn't mean that you have to start doing it, right? Like you need to evaluate that. So with federal, that's a great part. And then there's the veteran side of things, which is completely different. And it's its own kind of animal. So with the veterans and TRICARE, there are first and foremost many levels to TRICARE. TRICARE.gov is amazing. Oftentimes when I'm working with a client, I will have it pulled up. We're talking. I want them to tell me exactly what TRICARE they're on, right? Because I never want to mess up a benefit. And I absolutely don't want to mess up a benefit that someone has sacrificed the way that our soldiers do, right? And not that everyone's not important, but like that's huge. And so one of the first things also that I want to understand once I know, oh, they're on TRICARE for life, I want them to understand, yes, you do have to go on Medicare on TRICARE for life because it's very black and white said by the government on TRICARE.gov that once you are eligible for Medicare, if you are on TRICARE for life, you must enroll to keep it. If you don't, you lose it. You don't want to lose that. And I think that all just comes down to Uncle Sam and it's like, hey, well, we are paying for all this, but now you gotta do this, right? And so there's those pieces. But then you want to understand, do they have drug benefits? Do they have them through the VA? Like what benefits are there? Because I don't want to mess that up. So it's just people taking the time, again, like we said, to ask you the questions, to ask you to bring, and it may take an extra day or two because they say, oh, I have to get a copy of that. But I know that you've told me before, you're like, hey, Mr. Jones, and I'm making up names, but let's go ahead and let's have your appointment next week so you can get a copy of that so you know exactly, so we know that decision, right? We don't want room for in Medicare and in your health plan. So both of those areas probably have some of the best coverage. There are private companies that have awesome coverage, but again, they may not need any kind of ancillary plan. They might. I know a lot of people who are on TRICARE for life, they don't necessarily need a supplement or advantage plan because they have a great TRICARE for life plan and maybe they have their drugs through the VA, but they're not happy with their dental, right? That's actually pretty common. One of the most common things that I hear, being in Topeka, we have an air base here. We have some Army reserves here. We have a lot of soldiers in this area. And one of the most common things I hear is, oh, my dental kind of stinks. And I'm like, okay, well, let's get you a standalone dental plan. Like, let's get you a little extra coverage and show you how this works. So just because you think you're covered doesn't mean you shouldn't at least take a peek. If you're covered, great. You don't need anything else. You don't need to waste money on things you don't need. But it's worth at least taking a peek to see what you could get.
So with federal employees and military personnel, the approach is really the same as let's make a copy of your current coverage, of your coverage card, and let's take a look at what medications you're taking, who are your favorite doctors, and then let's compare that coverage and what you're paying to what's available out there. And often it doesn't make sense to change anything. You may have the great plan, but it certainly doesn't hurt to take a look at what you have versus what's available out there.
Yeah, I love what you said last week when we were talking and you said trust but verify, right? Trust but verify. Go ahead and get the copy of the card. Just because I get it. If something like that is wrong and you're upset later, I can't fix that. I can't change that necessarily right away. Maybe I can, but also you told me, and I don't want to be like, oh, well, you told me that. Instead, I'd rather be like, can I see your card? like just bring your card with you, right? Like, so I think that it's great. And let's face it, with what you're doing and the people that you're helping people, I know that, you know, you talk to people and there's always different things you're evaluating, but it's, you'd rather look at it and make sure they're warm and comfy and they know that they're getting that help from you, even if you don't place something, then, you know, they'll never look at it and find out they could have been going and getting your teeth cleaned all these years. And, you know, we know there's a huge correlation between your oral health and heart disease, right? Like those things matter. So
Right. Surprising, but that is the truth. Okay, so well, thank you for taking the time today, Kim, to thoroughly go over all of these important points. And I feel like this is a great start for a lot of folks who'll be watching this to start thinking about looking at the options and putting together a thorough strategy on their healthcare coverage going forward.
yeah, thanks again for having me. Like I said, I love being partnered with agents such as yourself who really are robustly taking care of their clients, being that client advocate. So, I mean, people in your area definitely are very lucky to have you. And it's just great to get to join and kind of geek out and talk about Medicare a little.
Well, great. And likewise, I think our clients are very lucky to be able to have you as a resource in a sense, indirectly, when I have questions about Medicare that I may not have the answers to, I can call on somebody like yourself, a true expert in the space, and you know, get the questions answered the right way. So look forward to our future conversations, and have a great rest of the week.
You too. Bye-bye, Gary.